In this presentation, we're going to talk about the first phase of the nursing process, which is assessment. You're very familiar with this from a previous course, so we're just going to do a quick overview of this very important phase where we basically collect data or gather cues, we validate that data, and organize that data. We use several different data collection methods as nurses to gather the cues that will together help us to draw conclusions and to drive our care. The first would just be general observation, using our senses, our sense of seeing and hearing and touching and smelling. And when we're talking about observation here, we're not talking specifically about an in-depth physical exam, but just more general observations that one might use in looking at how a patient or family would present. Interviewing is another important data collection method that we use, and this is a very important skill that needs to be developed. Good communication skills are really critical to appropriate assessment. Your book details out some phases of a good interview that would include a preparatory phase where we really lay some foundational groundwork in terms of relationship, and then an introductory or orientation phase where we are purposeful about the kind of information that we are looking to gather. The main information is gathered in phase 3, which is the maintenance or working phase. And then finally, it's important to have that termination or concluding phase at the end where we're making sure that that interaction with our client or patient has concluded clearly. Other important data is gathered through physical examination. And this is something that you're spending a lot of time in the laboratory learning, how to do physical assessments. As you know, the major portions of a physical assessment include inspection, palpation, percussion, and auscultation. And for almost all the parts of the body, we do that in that order, but we do switch it up for any abdominal exam where we actually will auscultate after inspection, but before we touch someone's abdomen, before we palpate or percuss their abdomen. The last data collection method that's here I just mentioned because oftentimes people refer to nursing intuition, kind of a gut feeling or a sixth sense that people seem to have. And that probably is more something that is based on experience rather than an actual sixth sense idea. But you will hear of that, and so I thought it was important to mention it. Generally, what we see is that the more expert a nurse is, the more they seem to have that intuition. So again, we are collecting data in a number of different ways during the assessment phase of the nursing process. The data that we collect can be categorized into two types, subjective and objective data. Subjective data are those things that are more covert, things that we can't know about as the assessor unless the individual expresses that to us, unless they tell us about it. So things like pain, the experience of pain, or nausea would be subjective types of information. We refer to those as symptoms, things that must be reported by the person experiencing it for us to know about it. Other data is objective. It is more overt, something that we can either see or smell or palpate, that we can measure in some way, and those we generally refer to as signs. So a sign might be a laceration that we can see, or a certain odor to someone's urine that we can detect. Or, much like we had the subjective symptom of nausea, we can have an objective sign of vomiting, something that we can measure, that we experience objectively. It's also important when we are looking at the data that we gather through the assessment phase that we document the source of that data. Data is either coming from a primary source or a secondary source. And for us, generally, a primary source would be the client themselves, and a secondary source would be anyone or anything else, another nurse, a laboratory test, the chart. Both are very valuable. We want to get information as much as possible from a primary source. Secondary source information is also very valuable. It's just important to note the source of the information in our documentation. If you need a little practice in thinking about primary versus secondary data, there is a little box in the Craven text that says apply your critical thinking, and so I would encourage you to use that little exercise. I wanted to speak a little bit more about how we elicit good data from our patients or clients. And a lot of that comes from asking the right kinds of questions. We want to be looking at our questions to see if they are appropriate for the situation at hand. One thing to look at is whether we're using closed-ended or open-ended questions. A closed-ended question would be a question that can be answered in just a single word or with a single point of data. So oftentimes people will refer to yes-no questions as closed questions, and that is one certain type of a closed question. Open-ended questions are those questions that elicit more of a conversation, that elicit more of a story. And oftentimes in nursing, what we want to do is to get our patients to describe things to us more fully. So instead of peppering them with a lot of closed-ended questions, we try to ask open-ended questions that will elicit more of that detail from them, and then give different probes or encouragements for them to continue talking. So both are appropriate, and we just need to be using the right kind of question in the right situation. For example, if I just need a small data bit, for example, if I need your date of birth, I'm going to ask a closed-ended question. What's your birth date? And you can answer that in just a single data point. That is a perfectly appropriately used closed-ended question because it's getting at the data that I want. I'm not going to ask an open-ended question like, tell me about being born and how that was for you. So you can see that's a little bit of a ridiculous question to ask, but those are the kinds of questions that we're all often asking people when we have them coming into the healthcare system, and instead of saying, are you feeling sick, and getting a yes or no answer, we might say to them, tell me what brings you into the clinic today. And that open-ended question is going to elicit a lot more good data for us. We also want to make sure that we avoid using biased questions. These can also be referred to as leading or loaded questions. These are questions that when we ask the individual, that we're almost giving them the correct or the right answer socially as we ask the question. We want to avoid questions that might make them feel a little backed into a corner and feel like they have to give a certain answer rather than being able to freely express themselves. So asking, for example, your husband doesn't beat you, does he? That would be a very biased question. Another question that we have to think about a lot is, do you smoke? And with our societal norms right now, the correct answer for that is no. And so if we kind of challenge somebody with a, you don't smoke, do you? Or do you smoke? And somehow in our tone, we are asking it in a way that they're going to kind of automatically and defensively say, oh no. And so instead we want to phrase that question in a way that is just more open, that is more accepting, and just allows them to give us the truth. So we might ask instead, tell me how much you smoke. And that gives them the option of saying, oh, I don't smoke at all, or I just smoke a little, or they can give us more specifics. They'll give us some information that we can then follow up on that and get more specific information. So those are some things about asking the right questions. Also, we want to make sure that we're paying attention to nonverbal communication. As the slide says, nonverbal communication speaks loudly. So as we are getting information from people, we're hearing not only their words, but we are observing their body position, their facial gestures, whether they're making eye contact with us as they answer questions, whether they seem to be very hurried or inattentive, or whether they're hanging on every word with their posture. So these are things that we want to make sure that we're paying attention to as we communicate. Another thing that we're actually looking for with nonverbal communication is incongruency. Sometimes we will see situations where somebody says something, but their body might be saying something very different. For example, someone can be grimacing and holding their hands and bracing their stomach and rocking back and forth, and we ask them, are you having pain? And they say, oh no, I'm fine, thank you. And there's something very incongruent about the words that they say with their nonverbal communication. So this silly little cartoon just will give you an example of that, of how oftentimes tone can, there's my phone, but I'm going to go on. Tone can belie what words are being used, or just the nonverbals in general can be incongruent with that. Just gives us a cue that maybe we need to pay a little more attention to things. As I mentioned before, good communication is a skill that needs to be developed and learned. Some people are more natural than others at it, and one portion of that is listening. And oftentimes people are, when they go into nursing, just naturally good listeners. And so for some of you, this might not be something that you have to work hard at. For others of us, this is a skill that actually we have to practice and really learn and think about much more consciously. Some of the aspects of learning to be a good listener are to really focus on what a person is saying. Take the opportunity to paraphrase what they're saying back to them, to kind of check in and say, is this what you meant by that? We need to just really slow down. We need to avoid making quick judgments, not rush the person who's trying to speak, which is very difficult in our high-stress environments that we are often in. We have a tendency to want to fill in the blank for somebody or complete their sentences for them, and that really is not helpful in terms of good assessment. And for the most part, we just need to learn to talk less to be a good listener. Interesting thing to think about is when you think about the letters in the word listen and the letters in the word silent, they are the same. And so oftentimes it's just a good reminder to say, I just need to be quiet. So those are some things that are important in terms of gathering data. Another important part of this assessment phase is validating that data, or double checking that data. And so we use some of the same skills for data validation as we did for data collection. So this flow chart just talks about how we identify cues, and then we will make inferences about cues. Sometimes we make inferences on just a single data point, a single cue, and oftentimes we're taking multiple cues together and inferring things about those cues. And then we want to validate both the cues and the inferences. There are different validation strategies. This slide lists several. We compare those cues to the knowledge base of what normal function is. So we often will take information that we have, and then we want to compare that to what is normal, what we know to be normal function. Oftentimes we will validate cues and inferences based on what we read in journals or in textbooks and websites. We just use resources there to validate. Sometimes that validation involves checking consistency of cues. So for example, if you take a blood pressure and you get a certain reading and you want to validate an inference that you're making about that, you might retake the blood pressure and double check. So you have multiple measurements of something and check the consistency that way. Oftentimes clarifying client statements will help to validate cues and to validate those inferences. We also want to be using one another. We seek consensus with our peers, with our colleagues about different inferences. So you might reach out, as a student, you're going to reach out to your faculty members and the other students in your clinical group. And then as you move ahead in your career, you'll have colleagues that you can use as sounding boards, and hopefully you can be that for them, to really help to see if the data and the inferences about that data seem to be valid. The final phase, or final step really in this phase of assessment, is to organize the data. Record that data in an orderly fashion. We can use a number of different frameworks to do that. One that is very helpful in keeping a nursing focus is the functional health pattern framework that we talked about in the last PowerPoint. Oftentimes with physical assessment data, we use a head-to-toe framework that actually really helps to simplify the physical assessment. And then, so we work from the top of the head and work our way down the body. And then the information that we gather in that framework can then be integrated back into a functional health pattern framework. So that is the assessment phase, and in our next PowerPoint, we will move on to the next phase of the nursing process, nursing diagnosis.